So let's touch on one of the controversies that you brought up, because you talked about ibrutinib-based therapy, and I think there, the subtlety there was that this was either ibrutinib or ibrutinib plus rituximab. Let's tackle rituximab first. Any value in adding rituximab to ibrutinib in the frontline setting, and what's that based on?
So based on the Alliance study that had patients randomized to ibrutinib versus ibrutinib and rituximab compared to bendamustine and rituximab in a 3-arm study, there were no differences noted in the progression-free survival between the two ibrutinib regimens. So ibrutinib versus ibrutinib plus rituximab, there was no improvement. So in practice, improvement in progression-free survival. So in practice, I don't see the role of rituximab being added routinely in the management of patients who are about to start therapy. So we would typically recommend starting at ibrutinib as a single agent.
And I agree, and that was also found similarly in the relapse refractory setting with ibrutinib plus or minus rituximab. No difference in progression-free or overall survival, and maybe subtle differences in terms of depth of response, but not worth, I think, the addition.
So the only group of patients where I would sometimes consider adding rituximab would be patients where I want a rather quick response to therapy. So I have had patients where they start with a white count of 500,000, and then their white count because of ibrutinib-related lymphocytosis would climb up to 700,000 or something like that. And there you would consider maybe potentially adding rituximab to gain faster disease control. Another group of patients where I've sometimes used it is patients who have membranoproliferative glomerulonephritis or other autoimmune processes that may need the addition of an anti-CD20 monoclonal antibody.
Well, rituximab is not the only approved anti-CD20 antibody. Obinutuzumab has some interesting data with ibrutinib in the frontline setting.
Yeah.
ILLUMINATE, you want to touch on that one?
Sure, yeah. So the ILLUMINATE study is actually combining ibrutinib with obinutuzumab, a novel anti-CD20 antibody, in comparison to chlorambucil plus obinutuzumab. So as we all know that the previous CLL 11 study has established that the obinutuzumab combining with chlorambucil is superior over chlorambucil alone and also superior to chlorambucil plus rituximab. So that study established that obinutuzumab is a superior antibody in combination with chemotherapy, at least in the frontline treatment of CLL. So based on that, this ILLUMINATE study used the chlorambucil plus obinutuzumab, a FDA-approved combination, as a control arm, and then comparing to ibrutinib plus obinutuzumab. So this included patients who has treatment-naive CLL who are 65 years or older, or for younger patients who has comorbid conditions. So with a median follow-up of 31 months, the ibrutinib plus obinutuzumab arm significantly prolonged the progression-free survival compared to the chlorambucil obinutuzumab arm. An estimated 30 months progression-free survival was 79% in the ibrutinib-containing arm versus 31% in the chlorambucil-containing arm. So based on this study, actually, the FDA has approved this combination of ibrutinib and obinutuzumab as an option for frontline treatment of CLL. Whether that is better or equivalent to ibrutinib single arm, there hasn't been a study to compare those two side by side, so we don't really know the answer to that.
So in your current practice then, are you using ibrutinib as a monotherapy or ibrutinib plus obinutuzumab?
I'm using pretty similar to Samir, is that for most patients I use ibrutinib as a single agent, but for a patient who has an extremely high white cell count to start with, I would add the obinutuzumab to help have a quicker cytoreduction.
And then just to push Samir a little bit more, because he did mention use of rituximab in autoimmune conditions. Are you using rituximab or is it obinutuzumab, just for teaching purposes?
So I think the ibrutinib plus obinutuzumab data have just come out recently, so I'm more inclined to use obinutuzumab if I really have to use an anti-CD20 monoclonal antibody therapy. And again, this is cross-trial comparison, so we, like you mentioned, don't have any data to support the use of obinutuzumab compared to rituximab with ibrutinib. There is the data from the ILLUMINATE study suggests that there is a higher rate of MRD negativity that happens after 18 months or so, compared to, again, this is cross-trial comparisons, but I think if I had to use an anti-CD20 monoclonal antibody, I would potentially pick obinutuzumab.